I'm going to call everyone. Okay, welcome to this webinar, some webinar on the consultations that are currently open from the government, Occupational Health Working Better, and one from the Treasury. This webinar is to look at people's thoughts about the consultation. I think you've all received the SOM consultation draft, and it's really to look at it in more detail. And we've got 4 excellent speakers, Steve Borman first, and then we've got Shriti Patani, immediate past president of SOM, and then Rachel Suff, we've just been talking about the launch of her COPD Health and Wellbeing at Work report, and their view is obviously very important considering the 160,000 membership of HR leaders. And then we've got some international comparators, which is section 2 of the consultation, and Laura Shentob's going to be covering that. And then we've got half an hour for questions, Q&A, so do sort of stay for that. It's an hour and a half long, but first off, I'm going to hand over to you, Steve, Chair of the Council for Work and Health, just to provide an overview of where we've got to and where we are and what we need to do. So thanks, Steve, over to you.
Good afternoon, everybody. Unlike the more erudite speakers that will follow me, I don't have any slides this afternoon, but I really wanted to just talk a bit about the context and the lead up to how we've got to here, because the consultation is a really important milestone. In fact, it's not one consultation, it's two formal consultations at the moment, but part of a much wider package of initiatives by the UK government. And yes, a lot of that actually covers England. I see Ewan on the call, but it's fair to say that DWP, which is a key stakeholder in this, extends its boundaries beyond the devolved health administrations. I think it's worth a little history lesson. Paul Litchfield reminded me when I used the phrase cobbler's children in the 2009 review of NHS staff health and wellbeing, that was not a new phrase. He'd used it in the early 80s in a review that he'd written for government in terms of access to occupational health services. Since then, there have been multiple reviews that have actually said that occupational health is an important contributor to productivity, to quality, to outcomes, to business success, and to the economy and the future of our NHS. Professor Sir Michael Marmot was very clear in his work early in 2009 and continuing since then, in terms of the role that work plays in terms of health inequalities. He identified 6 key domains that influence the health inequalities across society. And it's fair to say that life expectancy, even in 2023, varies by some 25 years across most of our major cities at the moment. We had Dame Carol Black, who highlighted that the cost to the economy of ill health amongst the working age back in 2009 was the cost of running a second NHS. And I think most of us on the call today would think that in this current era, and many people say post-COVID, but just prior to the call, we were saying we're definitely not post-COVID. We've still got COVID, and we've still got the long-term effects of COVID, both infective and non-infective in terms of the changed health behaviours that it actually generated. So that cost is probably higher significantly today than it was, and likely to increase because our backlogs in the NHS of undiagnosed, undermanaged long-term conditions and long COVID. I see Ewan on the call, and Ewan shares my passion that long COVID is a significant health issue going forward. We had the Waddell and Burton reviews actually showing that good health is good for good for health. And we've had multiple reviews since then. The Society of Occupational Medicine, King's Fund, Vedette Trust, Point of Care Foundation, Royal College of Physicians, Royal College of the Royal Chartered Society of Physios, and so on and so forth. I could mention dozens of them that actually make the case for why occupational health is something that actually in 2023 should not just be available to something like 45% of our working population in the UK. And that's shameful. It's worth remembering that this pair of consultations that are currently on the table don't stand alone. They're part of a much wider government agenda. We've got the wider Health is Everyone's Business agenda, who now have an extra £50 million worth of cash in England to actually pilot access to occupational health for small businesses. We have these two major consults that we're talking today, the growing occupational health and well-being, not growing occupational health and well-being, but the extending occupational health consultation, and the Treasury consultation in tax and financial incentives. We've also got the multiple conditions framework strategy that was announced on the back of the consultation exercise run about 6 or 8 weeks or so ago. That's important, and it's frightening that actually, despite very strong feedback, occupational health is not strongly mentioned in the draft framework strategy, and it deserves to be, because occupational health should be alongside mainstream care in the management of major conditions. And for the first time now, we've got real economic recognition. We've got Treasury Office involved. We've got Cabinet Office involved. We've got the DWP, the Health and Inclusion Unit. We've got the Department of Health. We've got multiple government agencies actually now engaged with this agenda and beginning to recognise that actually occupational health is not a cost, but is actually part of the solution and is going to be essential to recovery. So I think we've got a once in a lifetime opportunity. And what I'd say to anybody listening is, wherever you sit in the great scheme of things, however junior or however senior you are, don't waste this opportunity to respond. Because actually this consultation needs or both consultations, both the one from Treasury and the one from the Health and Inclusion Unit, really do need a very robust response. And the one thing I would urge you to do is not be negative. You might actually disagree with some of the questions in the consultation exercise, but if you do, suggest the alternative. Suggest what can work, what your opinion is about what the solution needs to be. Because we only get one crack at this, and from my perspective, having been working and campaigning in this space throughout a career, Ewan taught me very early in my career that actually you sometimes need to work at these things over a particularly long period of time, and it does seem like a long period of time, but we do really feel at the crossroads now, and these consultations are hugely important at this point in time. Thank you, Nick.
Thanks very much. Also, just to say, we do have a colleague from the DWP who's the stakeholder engagement lead, Mofifo Lua Jaebu. Welcome, and she's available to take questions throughout, I imagine, but also particularly at the Q&A at the end. So welcome. Okay, thanks very much. So I'm looking for Shriti, if she's here, to follow that up. I'm not sure if she's joined yet, in which case I might skip Shriti and move on to you, Rachel, just to offer the HR perspective. Thanks for joining, Rachel. I know you've had a very busy day launching a report with multiple media calls on your time. And Rachel's really great colleague, sort of partnering with CIPD, but just a plug on a Occupational Health and Wellbeing, HR and OH working together report we're producing with CIPD in November, and clearly it's this link up with HR within businesses that is critical for the success of occupational health to scale up. But I'll hand over to you, Rachel, and thanks very much for your time today.
No, you're welcome. Thank you for inviting me and convening this webinar. I think it's a great opportunity to discuss the consultations that Steve outlined. And I think you know who I am from that title slide. I lead on health and wellbeing in the public policy team at CIPD. And if we just look briefly at what the CIPD is, we're the professional body for HR and people development. So very often in organisations, we will be commissioning occupational health services and other support and so on for people. We've got around 160,000 members worldwide, mainly in the UK. And on the right-hand side in the orange circle, you can see that our purpose is to champion better work and working lives and promoting good health and wellbeing, looking after people at work, making sure that work doesn't make people's health worse is a really core part of that purpose. And amongst our membership as well, I just want to highlight that we've got a lot of members, around 16,000 in the UK, who are consultants, and they're working predominantly with small firms. And I've really tried to talk to as many of them as I can and just really draw on their insights, because I think quite a big focus of the consultation on working better is around how do we improve coverage and demand amongst small organisations? What are the barriers? What are the opportunities? And so on. So I'm trying to bring some of that insight from HR, and particularly our HR consultants today. So first of all, on the value of occupational health, just drawing on, well, today's research that we published, which is the orange survey report, looking at health and wellbeing at work and sickness absence through the eyes of HR professionals. But we've been running it for 23 years, so we can really look at changes over time. And 3 years ago, the green report, we did a bit of a deeper dive into occupational health that Sam and Nick were really great at supporting us with. So I'm drawing on that research as well to see how occupational health is perceived, used and valued and so on in organisations. And the report that we published today, that covers over 900 organisations, and collectively that's 6.5 million employees. So that's quite a big section of the labour market in the UK. So quite authoritative practitioner research. So first of all, we find that nearly 3/4 provide occupational health services for employees, and that rises to 95% in the public sector, mainly outsourced. Now that was 2020 research, but similar findings in today's research as well. But obviously HR is only present in organisations of a certain size, so that coverage, that's why it's higher than reported in official government statistics. And in the consultation paper, it's a bit higher because organisations are bigger where there's OH, and that's where there's more likely to be occupational health. Occupational health is definitely valued by HR members. It's a key approach in terms of managing long-term absence. And if we think about long COVID, and we were talking about that just before the webinar started, I don't know if you caught it, but COVID's still very much with us, and long COVID as well. Organisations support people with long COVID. But when we move on to smaller organisations in the SME sector, which there's quite a big focus in the consultation document, we can see that organisation size really matters, and the experience in smaller organisations in particular is very different to what I've described in terms of larger organisations where there's more likely to be HR. So first of all, the consultation recognises this. It points out that in larger organisations, you've got 92% coverage compared to 49% in medium and just 18% with in smaller firms. And I think that really does outline how diverse the SME sector is. It's not homogenous. There's a world of difference between an organisation with, say, 15 employees compared to 230. Different business challenges, different people management capability, knowledge of employment and health and safety law. So I think that's our first point really about occupational health and what kind of model would work in terms of improving access to quality OH provision in the UK, we really need to segment that SME market and understand its diversity. Also, we've carried out quite a lot of in-depth research, live research projects going on for about a year or more, and we're about to embark on another one, involving small firms of under 50 employees, and we offered free HR consultancy, very high level of expertise to small firms, but it was very interesting and we learned a lot about the needs of small firms. First of all, didn't necessarily want it, only where we had really good links in the local business network, where there was word of mouth, where there was trust, where there was relationships and so on, and through LEPs and growth hubs and so on. That's where small firms actually wanted to access free HR advice. So I think there's a real issue around improving awareness in small firms of the need. What is occupational health? What we found was that we had gone in with the idea that we will offer transformational HR to really elevate people management, health and well-being in these small firms, but actually it was very transactional, and you had to get the people management sorted out right. They were interested in basic contracts and things like that before you could move to another level. Often these small firms, or very often, operating on very tight margins, and affordability, even for the cost of an occupational health assessment, is a really significant barrier for them. And very much welcome the pilots that government is running at the moment with the 80% subsidy. But in the view of many of our HR people, really there's a lot more hand holding that's needed, needing to be guided towards appreciating the need for occupational health. Very often our HR consultants are there convincing, advising of the need, that it is value for money actually, having occupational health. So we very much support a nuanced approach in terms of getting the right market model, and we think it should be free actually for smaller firms. So that was the first point. But delving a little bit deeper into the view of HR professionals, yes, we need to improve coverage, definitely, but in our view, we need to shift how occupational health is viewed and used. And this is a conversation and work that we've been doing with SOM as well, and Nick alluded to our policy paper that Kevin Towu of Birkbeck University has drafted on how occupational health and HR can work more effectively together to improve mental health and well-being. So that's in progress at the moment. So really value views on that. So that paper, I think, underlines an important point about occupational health, because in terms of HR, very valued, but it is used primarily in a reactive way. And the majority agree that occupational health services in their organisation are primarily used for referral in cases of long-term sickness absence. So where you've already got quite a significant problem in terms of health and absence. And then the second bullet, far fewer use occupational health, that really valuable expertise, in a more proactive and preventative way. So for example, less than 3 in 10 agree with the statement that HR and OH work closely at a strategic level to help prevent ill health. And that's where we feel at SOM as well, I think I can speak for you on this, that where we could come together more closely in organisations to really develop a more risk-based, evidence-based, systematic approach to help, well, mitigate the main risks to people's health and prevent ill health where possible. So that isn't happening on a large scale according to our research at the moment. So the third bullet, you can see just 1 in 3 use occupational health specialists to prevent or mitigate the risks to mental health, or to develop a mental health policy. So we could be tapping into that valuable expertise at a more strategic, earlier level. And then the final bullet, well, these are findings from today's research that we've just published. We ask organisations, what measures do you take to support people's mental health at work? And you can see here that reliance on mental health first aid training, having wellbeing champions, is far higher up the table than actually relying on occupational health services. So we need a rebalancing here. There's a lot of different factors that could make up an effective framework in organisations to improve mental health, but we need to really focus on those evidence-based approaches. Also the role of line management, not in a medical sense, but we need to get the balance right. So just to look, so those are some early thoughts on the consultation. Just a few more. First thing to say is that we really welcome the consultation and the focus on the pivotal role that occupational health services can play in improving health outcomes for people at work. And we've got evidence and research like the value proposition from SOM showing that already. So really important that we draw on that evidence base. We're still fine-tuning our response because what we're doing is really making the most of this document to have conversations, have a dialogue. As I've said already with our HR consultants and our other membership, also here, it's a great opportunity as well because it's not necessarily straightforward, I don't think, to develop an occupational health offering that's national, that works at a local level, that works for businesses of all size, with employees with a whole different range of needs, and making sure as well that that occupational health offering is quality. So we're fully behind the overarching aims of the consultation, so scaling up coverage, developing that skilled multidisciplinary occupational health workforce to deliver on it, fully behind that. As I've said, in terms of SMEs, I think it's really important that we increase awareness of occupational health, understanding of it, of its value and the benefits that it can bring, because I think we need to boost appetite for it and demand rather than impose and have top-down legislative approaches. I think it was very interesting to read about the different approaches in different countries, and I think you can take inspiration perhaps from some of them, but I think particularly in terms of small firms, I think quite difficult to transpose some of those sort of legislative mandatory approaches. We think we need to start really more with a big education piece and reaching those harder to reach smaller firms in particular, and dealing with some of the barriers like cost and awareness in the first place. And I think locality has come through as a really important theme from my discussions. And I think some of the local delivery models that are being tried, well, one that's being trialled at the moment in particular, that's really interesting. Working alongside primary care, where there's a link to GPs, and it's a proactive approach looking at fit notes, and it's integrated as well with ICSs. So I think it'll be really exciting to see that the results of those trials that are running at the moment. That's, I think, the kind of approach we need, because I think it's very hard to go in cold to small firms in particular, and for them to actually commission, have the confidence to commission an occupational health service on their own. And in terms of quality assurance for occupational health, yes, of course, we need a simple and clear baseline for quality OH provision that, like the consultation outlines, but I think we've got industry standards already for providers of OH that's been reviewed. So we're quite hesitant to support a new benchmark or kite mark. I think as a principle, it's good to, but we defer to you occupational health experts on what's needed in terms of quality assurance for occupational health. But in terms of another proposal around a new national voluntary health at work standard, we have reservations that would shift the dial and increase demand or awareness on its own, especially amongst SMEs, and really build that employer confidence. And we have benchmarks, we have schemes already. So I think the risks that are set out in the paper do outweigh any hoped for advantages from introducing a new kite mark standard. I think there could be duplication, I think there could be confusion and a lack of employer capacity to really effectively implement a new standard, and a lack of traction with smaller firms. I think where we have got well-established frameworks already, like the Mental Health at Work commitment, there's a Thrive at Work initiative in the Midlands. I think expanding those, building on those, incorporating more specific reference to occupational health services, I think that would be a better approach. And then I think really, just to sum up our response here, I think it's just being aware as well that employers need to be engaged for occupational health to work effectively. HR needs to be engaged, and employer owner managers in smaller firms, senior leaders in framework, that culture of health and well-being. So it is part of a bigger piece, and I think I'm glad that the consultation does recognise, it mentions the role of robust line management to support and enable beneficial conversations about health and well-being. And I would just expand that to say we need supportive, capable, confident line managers as well, who've got the skills to understand their role. There's a lot of expectation on line managers, and they are at that front line in terms of managing day-to-day sickness, absence, adjustments to people, return to work. There's a lot of responsibility on them. And again, we think there would be, it'd be great to have occupational health input within the bounds of patient confidentiality, developing guidance for line managers and so on. And then just broadening out even further really in terms of health and work. Last week we published our manifesto for good work, and in that we really want to highlight the importance of quality occupational health provision as part of good work. And we do think this is the opener for the manifesto, and we do think we have a broken employment and skills system in this country, and we think far too many people are experiencing discrimination and inequality in terms of employment opportunity and health and income. And some of the chronic issues facing our labour market and the people in it and the economy as well mean that it's a real priority, there's real urgency around health. And a lot of these that I've called out here do relate to health, and occupational health has got such an important role to play in terms of dealing with some of these issues, people leaving employment because of work, the growing number of people experiencing work-related stress, and so on. And we've got three main areas for policy calls: skilled work, fair work, and healthy work. And these are our policy calls, just the headlines for healthy work. So we see it as quite, well, a priority area that needs a lot of priority action across a lot of areas. Enforcement, more focus on stress, better enforcement, occupational health is in there, reform of statutory sick pay. We're calling for, we used to have a director for work and health, and we feel that's needed again. And I think this is a call of SOM as well, so it's great to be aligned on that. So we need a lot of change at a lot of different levels, I think, and occupational health is a really important part of that. and also just how our two professions, HR and OH, can work more closely together, because I think there is more scope in organisations. So those are some key thoughts, just to say thank you.
Brilliant. Thanks very much, Rachel. Great leadership from CIPD, and I love your manifesto. And again, thanks for your time today, because I know you're busy, working those studios for the launch of that report, which is very important, particularly with that increase in sickness absence. I'm hoping, Shriti, you're available and able to share your slides. Shriti, you there?
Good afternoon, everybody. Yes, just jumped on. Apologies for the delay. Just finished my morning teaching session. Nick, have you got the slides? Can you put them up for me if you have?
Yes, no, I can do that. So I'll be your next slide, please,
person. Yes, yes, please.
Just a second.
Nice to see so many colleagues on the call this afternoon.
Do you want to introduce yourself, Shriti, whilst I do that?
What a good idea, Nick. Thank you very much. That's why you're chairing. Good afternoon, everybody. I'm Dr. Shriti Patani, immediate past president of SOM, and also the national clinical expert for occupational health and wellbeing for NHS England. And my other day job is that I work as a consultant in occupational medicine for a large acute trust in London. I'll just continue, Nick, with some of what we want to say this afternoon. So again, really kind of, welcoming the consultation and knowing that we're all on the same page here, listening to Rachel and some of the asks that are coming through from CIPD being aligned with what, we are asking for alongside colleagues like the faculty, and we're all singing, from the same hymn sheet as our RCGP and others, and that's really reassuring that now maybe we can make real traction in provision of adequate work and health advice for all people of working age. Nick, I'm going to run out of things to say in a minute. Sorry, shall I?
No, it's fine. I'm going to share.
Got it?
I've got
you.
it. Hopefully, I've
so
permission to share.
I'm whilst Nick gets the slides up, some of you will know, and I know certainly I've spoken to you, in that we are, there's lots of pilots going on in different areas of the country that are supporting a multidisciplinary approach to delivering universal occupational health. So
can you see that, Shriti?
Yeah, I can. Thank you very much. Okay. Yes, thank you. Thank you for this, Nick. So I think really since COVID pandemic, I think occupational health certainly has got a different profile, and at least in my service or in my hospital, people have gone from saying, what do you do, Hep Bs and flu jabs, to actually understanding what occupational health might be and the range of things that we do. Over the course of this year, we've had lots of opportunity to be able to promote some of that at the House of Lords, and also we were contacted by the BBC to talk about this. So the word is getting out there, and having the occupational health consultation that's been launched, and as many of you will know, the deadline for submission for that is the 12th of October, soon coming. It's great that all the work that we've all been doing has actually taken us to the point that there is this consultation, and a real desire behind the consultation to actually make a difference by you know, a lot of interest from the civil service, the DOH and DWP, and I think many of you will know from some of the webinars that they've held and the round tables. There was one last Thursday where there is a real kind of let's actually do this time. We've had consultations before, so a real critical time for us. And we've got a CMO, Chief Medical Officer, who understands occupational health and actually is on our side to make that difference. Okay. Next slide, please, Nick. So in a way, I think some of this has already been covered, but we've actively at SOM been involved in actually getting involved in all these consultations, and you know, particularly in promoting how occupational health can be a part of the solution of those who are reducing worklessness due to ill health, which, as you know, is a big government agenda. 2.5 million people economically inactive due to health conditions. And along with the Faculty of Occupational Medicine, the National School, we've all actively been working together really to try and help the civil service, the health and work unit, to create solutions to offer this in a way that can be actually rolled out rapidly and yet be fit for purpose. And with the desire now and the momentum that we have, this I think is a real opportunity for the world of occupational health to take absolute leadership in this space. And just listening to Rachel there, great that the CIPD are partners in this journey. Next slide, please. So in the budget this year, we've had you know, several good measures, and you'll know about the dedicated money for mental health and MSK support for people of working age, which was announced earlier on in the budget, in the spring budget, and we're hoping that the autumn budget will bring some more delights too. And I know that NHS England are actively working on both MSK and mental health support for people of working age as a result of the budget. The consultation recently, the occupational health consultation, but we also have the consultation that, about small and medium-sized businesses and incentives for tax breaks to access occupational health, and that consultation also comes to a close very soon. So all going in the right direction. Next slide, please. I've already mentioned the 25 million for a subsidy pilot for SMEs to access occupational health, and I know from discussions with DWP that actually there have been some interested bodies in doing some of this, and you know, they are still looking for any other ideas. So if you have any, do have a look at that fund, because there's a real opportunity to pilot something that could potentially be part of an evidence-based decision for a national rollout of occupational health in the future. And the two consultations there at the bottom that we've already mentioned. So in the budget, we also had, I've already mentioned there about the MSK and the mental health online tools, but there was also a 3-year pilot announced. This is in the spring budget, which is called Work Well, and it's low-level non-clinical biocycle support, largely from non-clinicians, but also from clinicians, to encourage people to return to work. The idea is that the service is actually based at ICS level, so it's local provision for across the ICS based on local need. We're waiting for some more detail about Work Well and what it will actually look like eventually when it is rolled out. And I believe that DWP are actively working on the policy to support the rollout of Work Well. Next slide, please. The major conditions strategy, it also sits alongside the national drive, and the major conditions strategy is actually looking at 6 major conditions and sort of the prevention, diagnosis, early treatment and management of these 6 conditions, of which MSK is a key condition. And of course, we know MSK is also a key reason for people having sickness absence, but also having losing work or actually being economically inactive. So the work that we're doing in terms of a national strategy sits very much alongside the major conditions strategy. Thank you, Nick. So where is the future? Well, the new CQOSH standards are already released, and Robin and the faculty have done a fantastic job with that. I think we're all agreed that we need a multidisciplinary approach to be able to deliver universal access to occupational health, of which the model needs to consist very much really of, and we do know that people that are trained like case managers can do the first point of contact for many people, who can then subsequently access other forms of, like a tiered service, which would and could include online tools, technology, multidisciplinary approach with physios, OTs, vocational rehab and other colleagues, and where required, occupational health clinicians, which of course would include doctors, nurses and others. There's a lot of other work going on in different local areas looking at outcome measures, but also fit notes, including quality of fit notes. The fit note, there's also a project going on in the health and work unit, which I think Amy Edens is working on, which is about improving fit notes and whether we can actually have an AI approach to fit notes, and other projects to look at how we can improve the use of fit notes. I'm sure you're aware that 90% of fit notes are actually signed off as unfit, which of course doesn't quite meet the agenda for which they were introduced. We've also had reports from the Royal College of OTs and others that although OTs and physios now are able to sign fit notes, that a lot of people don't feel confident in doing so, don't feel they've had the background or the training to do so. And I know that that's another project that's being done, which is to look at how we can actually improve the education side for colleagues that can now sign fit notes. And I think the other big area here is about the role of the line manager in supporting the whole kind of health and well-being agenda that we have for the working age population, and the importance actually of the work environment, the work design, and in keeping our working age population fit, healthy, and working. Next slide, please. So I think, again, we've all been proactive. I think all of us who are leaders in the world of occupational health and have come together really to lobby, you know, the government as one united voice, which I think has been incredible, and we've linked very well with DWP DHSC. There are actually some conversations going on with the CQC as well about occupational health, and also with the HSE. So we're learning from other countries, such as the Netherlands, which have a mandatory return to work plan, and again, you know, that sounds like a fantastic thing to do, but they are dealing with a population number that is a lot smaller than our population, and we've seen some of the work they're doing, which is excellent, but actually would be quite difficult to establish here and quite labour intensive. There's also lots of work going on to get the OH community ready to take on more work for the future. Both DWP through the National School have been supporting funding for more places in the diploma course for doctors, for nurses, and we're hoping that in the future the nurses diploma course that the faculty have approved will be available more widely to OTs and physios, but there's certainly an NHS England have also been doing the same to get more support in the NHS, and they've funded places for nurses and doctors on the relevant diploma courses. And what's been particularly you know, I suppose successful, and I know Steve Borman, who's on this call, has been actively involved with this, is the leadership courses that have been invested in for you know, leaders in the NHS to take on bigger roles in occupational health, and you know, we've developed and upskilled our staff, and that's been hugely successful. We've had so much interest, and certainly more interest than places. So watch this space, because there is going to be more funding to you know, give more opportunity to our up and coming leaders. Next slide, please, or I might be hoping that this might be coming to an end, because I know
this is the second to last one.
Okay, because I'm running out of time, I know. So really, I suppose the biggest risk for us at this stage as an OH community is if the government lose a momentum in this area and lose interest, although based on the figures that we see of the economically inactive, I think the agenda is very much still on our side. We've got to be ready to deliver. And as an OH community, we are all speaking in unison, and there is a lot of momentum across DWP, civil service and the OH community to deliver a service that's fit for purpose. And of course, as I said, our CMO is very much behind us. Final slide, please. So we've already covered a lot of this, you know, we've got a consensus way forward with our OH colleagues in the National School Council for Work and Health, FOM, SOM, etc. So, you know, that's fantastic, and we're kind of lobbying for more investment in the autumn statement, which would be really good, and looking at different implementation models that meets the government's agenda. So it's a fantastic time for all of us, and you know, thank you for listening, and Nick, thank you for being a gem and helping with the slides.
Thanks, Shruti. Now, I know you have to go, but thanks very much for running through that, and you've been instrumental in getting this top of the agenda. So thank you. So we've got last presentation, which is from Lara Shentov. Shruti, you're welcome to stay, but I know you have to shoot off, and I'm sure we can answer questions, but if there are any questions, obviously I'll pass them on. But thanks so much for your time. So Lara has been supporting SOM in terms of our advocacy. Thank you, Lara. Given her a grand title of strategic clinical advisor, and she's got some useful slides just in terms of what other countries are doing, what we can learn. This is section 2 of the consultation. As I said, you've all got SOM's consultation, draft consultation response. Welcome to use that, submit it on your own or contribute via SOM. So Lara, over to you. And also just one final thing I wanted to mention on the chat, if you are a researcher or you do have a pilot, there is £20 million that the Treasury has announced for research synthesis and evidence reviews and pilot projects. So do look out for that. It's got a very quick turnaround, but you can see they're working rapidly because there is obviously a current problem with ill health. But what we can learn from other countries. Over to you, Lara, to tell us more. Thanks.
Thanks, Nick. Hopefully you can hear me okay. It's a little bit busy where I am.
Yeah, that's fine. Yeah.
So yeah, just thinking a little bit about what the UK can learn from other countries. And Shruti mentioned looking at the Netherlands as a case study. I'm Lara Shentov. I work between the Department of Primary Care and Public Health at Imperial College London, general practice and occupational health. So I think the most comprehensive published work on what the UK can learn from other countries came from the DWP in 2021, where they had a look at 12 other countries, looking at their health systems, their healthcare systems, their occupational health systems, and the types of provision they offered. And that report's really interesting to read. And it basically splits the landscape into two kinds of countries, one where occupational health is mandated through a single act, and in that scenario, which we can see in countries such as France and Germany, occupational health services are mandatory for all employers in the private and public sector, and therefore most of the working population has access to occupational health funded by employers, with the exception of people that are self-employed and a few other exceptions that find it more difficult to access services. Type B, which the UK fits into along with the US and a handful of others, is a more fragmented legislative framework. So there are, as we know, things like the Health and Safety at Work Act, which kind of creates responsibility for employers, but occupational health services are not specifically mandated within that. And that's where we get this quite patchy coverage, as historically we see here in the UK. So in terms of looking at other countries, there are different levers. So one of them is regulation, as explained with those type A countries, ways that employers fund occupational health access, such as through insurance, taxation incentives, market forces, which I'll speak a little bit more about when it comes to the US, where obviously there's a very close relationship between employers and healthcare, because lots of people in the US access healthcare through work insurance. And then the other thing is other countries have established centres for work and health where research and policy and practice are kind of always top of mind, and that helps move things forward. And I think it's good that we are having more of that kind of activity here in the UK as well. And there are also these disincentives. So one of them is the corporate wellbeing space, which I think is really difficult for employers to navigate, knowing that they're spending money on evidence-based interventions compared to wellbeing interventions that may not always be evidence-based. And another thing that's been highlighted is the complexity of the provider landscape, which again, I guess relates to that first point in terms of how they navigate what they're trying to achieve. So just very briefly going to have a look at two case studies here. They're really different, and both of them have been on my mind recently. So starting with the US, obviously such a low regulation environment in general. It's a type B country, so similar legislative framework to us. They also have state as well as federal legislation to contend with. That means things can look quite different in different parts of the US when it comes to work and health regulation. But the thing that's really interesting is that around 60% of the US population rely on their employer for healthcare through insurance, and about 55% of the time that is through self-insured employers. So employers take on the insurance kind of in-house, and that makes for very, very aligned incentives when it comes to work and health. They're trying to keep their costs down when it comes to employee healthcare, but they're also they really see how that lines up with employees' workplace performance as well. And so I've just put one case study on here, which is a retailer based in Texas, employs almost 100,000 people, and it's a self-insured employer. And in that business, health promotion is carried out through work, with financial bonuses to those that remain well or take action to improve health results following the results of screening. So for example, if an employer had a chronic condition and they were doing health activities to promote their health, they would get lower co-payments on their insurance as a reward. So it's just really interesting to see how in a low regulation environment, market forces can also work to improve work and health. And Japan is a completely different scenario. So we recently had a Japanese occupational health physician who worked for the Department of Labour there, called Yusuke Noguchi, here in the UK, studying for his MPH. And he did a lot of work on shedding some light on what's going on in Japan. So they have a very high regulation environment. They've had this single legislation, the Industrial Safety and Health Act of 1972, on the scene for a while. And basically that has mandated companies employing 50 people or more to have an occupational health presence. And most people, most companies sort of fund that themselves, but you can also apply to the government for funding for that. And what they found since is that there's been a huge workforce change in the medical workforce, with around 1/3 of doctors in Japan are now undertaking some kind of occupational health qualification. They have a really big centre for training and work and health research based in a university. And again, that was driven subsequent to the Industrial Safety and Health Act of 1972. Then that university was established to meet that need. And they also have used workplaces to support with general health promotion, things like BMI checks and other bits and pieces. And again, workplaces are incentivized to kind of cooperate with that, because they get sort of certificates to show that they are employers that promote health. And they've also recently introduced the FitNote. I think they only recently introduced it like 3 or 4 years ago. But because they have so much occupational health access, occupational health clinicians are key in implementing the FitNote there. So instead of it being kind of between the GP and the individual, occupational health weighs in, and the FitNote journey starts at the workplace, and the occupational health clinician liaises between the employer and the treating clinician. So that seems to be working quite well compared to what we have here, which as Shruti was saying, the majority of the time FitNotes are used to sign people off as sick notes. So yeah, I just thought those 2 case studies are really interesting. I think the other thing to highlight in terms of how things are going is the Health Foundation have released a report recently talking about the challenge of what the health service is going to look like in, say, 20 years' time, with less people able to work and contribute to government revenues compared to more people who are depending on the health service. And therefore looking at obviously trying to get people back to work and making sure people can continue work is one side of it. But the other is, how can employers kind of help support general health care? And I think it's really interesting because both the US and Japan are sort of case studies that demonstrate an aspect of that. But yeah, that's it from me.
Thanks very much, Lara. That was brilliant. And some useful things in the chat too. There's a summary comparator of health systems that Dominic Gonzalez put up, and some great comments from Richard Heron about the role of the CMO. So actually, Richard, I don't know whether you want to, now we're entering a kind of Q&A comments that might inform our consultation response or your consultation response. I don't know if Richard, you want to comment, or Ewan, legends in the sector? Any comments or questions, welcome. And hopefully Steve, Lara and Rachel, maybe myself, can kind of deal with these questions or just have a general discussion. And anyone want to go first? But thanks to all the speakers, Rachel, Lara, Steve and Shruti. It's really a great overview of where occupational health is and how others see occupational health. And also what's going on internationally. As Harry said, superb overview of different countries of OH, Lara, thank you. Any questions or comments, Richard?
Well, just fantastic context from all the speakers, really superb. Little to add, except that I think within the consultation, the SOM report, there are opportunities to just add a few little extras in there to really strengthen it. I mentioned the CMO role. Obviously, the government consultation is focused on SMEs and smaller employers, but I think there's something around perhaps also getting some comments in that are more strategic and broader. So, CMOs, all large organizations should have a chief health officer of some sort. And I'm certainly working on that with the World Economic Forum in another piece of work. And that's also where you've got influence of boards in terms of some of the strategic moves they make, linking the agenda to ESG, linking the agenda to climate and health, linking the agenda to a whole series of other things that are relevant to those employers. I think that's important. I also think, that, and I mentioned it in the chat, we're focused on the OH function and the response there, but really, it's the leaders of organizations who decide whether they're going to have occupational health or not, whether they're in HR or they're CEOs. So future leaders, where do they get trained? It's MBAs, these sort of trainings, and there's very little on health and productivity in there, and there's even less that has any connection with people who work as health professionals in occupational health or health professional role holders. So I think actually having some of that more baked into syllabus of those MBAs is about really sort of building the knowledge base, the intellectual purchasing of occupational health services of the generation of future leaders. And that's the pull that we need, as well as this kind of push of what the sort of regulatory driven side of it. So as I say, those are just a couple of comments. I put a few more in the chat, but I think great piece of work, Nick, and all in terms of marshalling the consultation.
Thanks, Richard. Yeah, I mean, you're right. I mean, I think if organisation can have a chief health officer, it doesn't have to be a kind of sort of massively paid chief medical officer or someone, but someone who leads within, rather than sort of contracting out to occupational health, who works with HR. That's a really great model. Steve, you got your hand up.
And Nick, just a couple of points. I think picking up Richard's point, I think it's woeful that we don't have a national director of occupational health, or at least the national director for work and health at the moment. And clearly Carol Black's role was established to actually do part of this in the first place, and that led to her seminal review. But it was taken out due to funding issues, basically. And now we're in a very different economic environment. So I do think that part of the consultation response should include that call. And I'm very pleased that CIPD have actually made that call, and certainly CWH, that I'm responsible for chairing, have also made that call, that the time is right to re-establish that role, and that role should have occupational health expertise. I think the other thing is, yes, we can learn from international administrations. And I think Lara's reminder in terms of what goes on overseas is actually timely and useful. But I think we need to remember that the UK is different. We do have a different legislative picture, and we do have a different employment picture. So we need a UK model, and yes, we do need to learn from the incentives that have actually worked and driven and been levers overseas, and I've got a lot of experience of those. But actually, this is the opportunity for us to be informing a UK model, and that's what the consultations are actually all about. Thank you.
Yeah, nicely said. You know, we are different from Australia and the US, and you know, shifting. So that would be a sort of political kind of tsunami, wouldn't it? So, you know, we are where we are. We need to work off that, but I think there's lots the government can do, are doing. So, Ewan, I can see you've come off mute. Have you got any kind of thoughts from your great perspective and experience?
Yeah, I think this is a fantastic consultation, a superb response, and some fantastic input to it from the speakers. I think we've got to think, we're talking a lot about big organizations. And big organizations have generally got occupational health, I think, as Rachel described. And with occupational health, as with everything else, it's the inverse care law that applies. The big organizations tend to be pretty good and pretty healthy. And it's the smaller organizations we need to think about, the micro enterprises, the home workers, the self-employed, who are rapidly increasing in number. So I think the model needs to change quite a bit from and that's been discussed by Shruti and others. The DWP coaches in primary practice, that is a fantastic step forward to provide some kind of universality. But again, that's reactive, and it's the illness model that's dealing with the chronic disease issue, which is probably the biggest issue of an aging working population, all with multiple morbidity. So nobody visible in this meeting seems to have any multiple morbidity that I know about. We need to be thinking of different models in terms of universal provision. One is certainly using AI. We use online web-based advice, can deal with a huge amount of issues. In Scotland, we have had that, and it works very well. 4 million hits a year it was getting before COVID. And that was a way people could access advice about any aspect of occupational health and safety. And I think we've got to see ourselves as wider than just the occupational health. If you're going to provide a service, it needs to be a sort of multidisciplinary. I think so we need to consider the models of health and what's the efficient way to do it, because there's not enough OH resources. There's been declining numbers rather than increasing numbers. So it's going to take time to have the huge number of resources we need for a universal service. So we need to think of an interim step, which is, I say, using as much technology as possible and AI as possible to deal with issues. The academic base, as you'd expect me to say, is very expert, but thin on the ground, and we don't have an academic centre. There's the loose collaboration in London, which is one, but that's recent. We don't have a centre the equivalent of the Finns. Finland have got a centre in Helsinki, which is at least 500 or 600 people, and Finland's smaller than Scotland. Each university in Finland has departments of about 50 to 60 people working in the big occupational health academic department. So we are very, very underprovided in that area. And the quality of what we've got is very high, but it's very thin on the ground. So we do need an academic base to be providing distilling and interpreting science into action. And so I think the view forward has to be a sort of one which is mapping a path which is based on what we've got, aiming at what we should have, universal occupational health, utilizing the various different projects that are in place, some which are already funded, some like the DWP one that Shruti is so excellently pushing, and that's a step forward, which it gives people advice to health issues. But the proactive side needs to be more evident. There needs to be more people be able to go and do workplace assessments and do risk assessments, and psychological risk assessments as well. And so I don't have the answer, but I think we do need to move forward, but not just build in the same way we're delivering OH at the moment, but look at dealing with something which addresses the whole population, the ones that are at higher risks, which are the SME side of the business, who don't have access to occupational health, and we need to build capacity.
Thanks, Ewan. Yeah, I mean, I think there's a quid pro quo with the interest from government. We need to match that in terms of our ability to be innovative, dynamic, scale up. If demand increases, we need to meet that supply. I'm keen to hear from people who perhaps are just sort of hiding, not on video, who just want to say, just you can say whatever you like. It really doesn't matter. Hopefully, it's relevant to this. But anyone who's perhaps not part of these discussions so frequently, welcome to just come off mute or say what you think about what you've heard so far. Can't see anyone. Anyone want to say? I know we've got Muffy for Lua. I don't know if you want to say hello from the DWP, just to say any comments. I know you probably can't, from a DWP perspective, say comments on content. Probably sorry, I got your agenda wrong. That's my bad. Apologies. But I suppose from the DWP perspective, what's important is getting as many consultation responses as possible. But have you got anything else to say to kind of help us with that?
I'll say thank you for the invite to join the call, and really helpful to get your perspective so far, and really interesting stuff that we're hearing, and really appreciate the responses that are coming so far. And we know we're working on them, but we'll just keep saying that we really appreciate the responses, and we'll take everything as much as we can into account. And yeah, thank you so much for everything. And that's basically what I have to say.
Could I just raise something?
Yeah.
Dory Miller speaking. I'm just wondering, for SMEs, often small companies don't have any understanding of what their needs are. And I think to impose our idea of what they need is not helpful, because every business is different, every person is unique. And I think to devise a way in which one can help smaller employers to understand what their needs are, their pain, because that's what costs. And unless there is collaboration, as been described throughout this morning, you'll never make them progress, because there's no point in having encyclopedias sitting somewhere in the business if there's no collaboration. And also, you'll never help them to get solutions to their pain unless you find out what that business pain is. That's the end of my comment.
Yeah, thanks, Dwayne.
So,
Yeah,
Nick,
yeah, go on.
it's worth picking up that that very definitely is in the Health and Inclusion Unit sites. And we have had that active conversation with the Health and Inclusion Unit with the fact that many small businesses are what I would call unconsciously incompetent, but would like to do the right thing. And it's how we reach them in a language and a messaging that actually can reach them, because many of the excellent publications that have been written in terms of how valuable occupational health is are just simply not getting through to small business owners. So that is very much part of the conversation at the moment. How do we not only provide to small businesses in terms of the capacity and the capability to reach them, which Ewan referred to, and there are mechanisms that would enable that to be built at scale quite quickly, but also how, having built it, we encourage people to come and use it, which is going to be key.
Yeah, absolutely. Tosin, I don't know if I can see you've come off video. Do you want to say anything?
Yes, I'd like to say something. Thank you, Nick. I just want to say thank you to all the presenters. Those were very good presentation. I particularly like Richard's idea of linking or emphasizing the link between productivity and occupational health. And that will get people's attention, future leaders and current leaders. If we can prove that good health at work will improve productivity and reduce costs in the long run, then we're a winner. And I also wanted to share with us the military model. I'm actually at work now, and we provide occupational health to everyone. And the main reason that's out with the NHS, the national standard. And I think the main reason is productivity. If you want to get the best out of your soldiers, airmen, and sailors, you have to provide them with occupational health. It's not just enough to say they're sick. What can they do, even though they're ill? And we base a lot of our occupational health on medical employment standard, which every person has a medical employment standard. So even if they are downgraded, maybe they're chronically ill and unable to do their full duties, they still can do something. And that is the main thrust of occupational health provision in the military. And I think that's a good model. But I think the problem we may have nationally, if we do have a way to get everybody exposed to occupational health, is like in the military, for example, for the reserves, even though we provide occupational health to them, we do not provide primary health care. So sometimes there's a disconnect with information linkage between their primary health care and the occupational health service. And so we can't judge effectively or efficiently what they are fit to do or not to do. So I just have a feeling that if we mandate small employers and if we're able to get everybody in the UK to access occupational health, we still need to get that link between the GPs and the occupational health provider. And that link is crucial. And as we progress with this work, we need to incorporate that link and not get one bit done, only to find out that, oh, there's a link missing. So that was just what I wanted to contribute. Thank you.
Yeah, thanks. I mean, I love the military's model. It's so great and comprehensive and focused and compassionate too. It's not about forcing people back to the front line as such. So yeah, it's a really good model for us to think about, and it is tied in with primary care. I think one of the challenges outside the military is primary care is so at capacity, and I think the message we got from sort of Treasury CMOs is that really the primary care shall not be touched in terms of taking people or using capacity. And so that's why this model that Shriti hinted in terms of linking with kind of work coaches, DWP staff, with people who work in primary care, but not so much GPs. But it, I suppose, then begs the question about how you get fit notes better interrogated and used more effectively. But so I think there has to be a primary care link up in a way that doesn't sort of affect GP sort of time or capacity. But I think there is a capacity in the system by that sort of DWP, Department of Health combi. Any other comments or questions?
I have, Nick.
Go for it.
My concern is about the well-being agenda, that well-being is more than Pilates on Fridays and fresh fruit and all that kind of stuff. Many managers, though, think that that's really good. What they should be thinking about is what's good work, and look at well-being from that perspective. Yeah, have a good diet in the kitchen, in the restaurant, staff restaurant. Make sure that in the NHS, for example, that day staff and night staff have equal access to nutritious food at work. Doesn't have to be Michelin starred, but just nutritious and available, and time from work to be able to go and get it. I'm not signed up to, well, let's have a few fitness things that we can do on top of the day at work. It's all about good work and having strategies within the workplace that allow people to be able to access occupational health services.
Yeah, I would totally agree. I mean, that's something that Rachel, we've been discussing, haven't we, of this report that is going to come out sort of later in November, sort of CIBD with the SOM on occupational health and HR working together on well-being, making sure it's evidence-based, data-led, strategic, rather than something that's a bit scattergun. And you know, I think of well-being washing as a term, you know, people might think it's a bit like wokey language, but you know, leaders are saying they're doing stuff when actually the organization is not having a concerted effect on that. Maybe for the best of intentions, they don't understand it, and obviously there's a role for people to work with boards and leaders on actually, you know, a good effective intervention looks like this. So I don't know, Rachel, before you hit the studios again, have you got any final thoughts on this?
I'm just really enjoying the discussion, everybody else's presentations, because I think it shows that this is a complex undertaking. If we're really going to get that understanding and demand from small organisations in particular. And I just agree with so much of what has been said, or all the points really. I think, yes, well-being, Anne mentioned, we're seeing a huge well-being industry now and a lot of noise in it. And it's not surprising that a lot of organisations where they really, with the best will, want to make a difference, are drawn into it and yet not sure what's good, what isn't. That's why they need, I think Richard put in the chat, if you had more trusted occupational health as that hand-holding advice, then that would reduce the use of non-evidence-based approaches. So yeah, really important that organisations don't put all their investment, because some are doing an awful lot on health and well-being, and our research shows that. But we're seeing more and more interventions around ones that don't necessarily have the evidence. So it is back to basics. But I think I agree with Doreen as well in terms of SMEs, particularly smaller organisations, really they need people who really understand their business. That has come through so strongly to us in all our research offering HR. They want a service where they're trusted, they're local, recommended, but really understand what their own challenges are in the organisation. So I don't think there's a quick fix, but I am really excited by particularly the pilots that Shriti talked about, those ones that are linked to ICSs and GP and clinical, non-clinical, you know, genuinely really, we won't see the results probably for a while, but I'm really interested in that. Financial incentives, really interesting to see what goes on in other countries. But I think we need more evidence around them as well, because they could become a bit of a tick box, and you could unintentionally incentivize the wrong behavior as well. So need more research really to make a sustainable long-term difference to health at work. I do think there's more scope for perhaps rebalancing responsibility and cost amongst state, employer and individual. I think some people, you know, self-employed are completely out of it, and I think there's more scope. Some of the small business HR consultants came back and said, actually, you know, things like group risk insurance, like group income protection, they're really cheap and, you know, could play a role. And, you know, there could be small businesses, you know, there's interest in there for critical illness cover. So I think we just need to see it as a whole. But really enjoyed the discussion, and thanks again, Nick.
Thanks, Rachel. You've got a better backdrop than I did. I did this BBC News thing yesterday, and it was in my bedroom with all my clothes sort of strewn behind me. So it's looking good, your backdrop. Anyway, so I think we reached the end. I might sort of
Nick, just before we
just hand over to you,
close,
Steve, for your final close. Yeah, thanks.
just before we close, I think we need to just address an elephant in the room here. And part of this is actually about the GP and how we better support GPs. And I think, you know, we should stop being critical about GPs signing off fit notes badly, because they only have, you know, 30 seconds to a minute in a consultation and just don't simply have the time to open up that fit for work conversation. So part of a better design for occupational health going forward will include the support that we actually provide alongside general practice to actually ensure that the quality of fit notes improve, and that those fit notes actually do reflect what people can and can't do. So I think that's part of the solution, rather than simply saying GPs have got to get better at doing fit notes.
Yeah, no, I totally agree. Yeah, you're right. Okay, so 2 minutes to, unless there's any final comments, I want to thank Steve, Lara, Rachel, everyone who's contributed today. The main thing from today is to kind of get a sense of what you might want to put in. You're welcome, obviously, to put in individually. Do let Som know about what you think about our consultation response. Just do submit a consultation response if you can. I think the more submissions, the better, in terms of government feeling they've listened and got a really kind of triangulated view. It's great that we've had DWP turn up to listen to that. I've sent them our slides so they can see that too. Just stay in touch. If you've got any queries between now and the 12th, do let us know. And otherwise, have a good rest of the afternoon. And thanks so much to our speakers for joining today.